It is my sincere pleasure, both as the director of the TRP and as the advisor to this group, to welcome everyone to our very first defense of the year during this second summer of COVID. I am going to take a step back and let Adita, who will be chairing the session, introduce the group and talk about the format that you're about to be participating in. Adita?
Yes, I'm muted. So hello, everybody. So my name is Adita Marcoin. I don't know if, some of you know me. So I'm the Capstone course instructor, and I'll be chairing this session today. And so the first thing I wanted to say, I want to echo Joseph and thank you all for being here today. We are very excited to have our first presentations for this year for this cohort and Friday afternoon. So it's good that there's so many people here. We would like to thank the committee members, but particularly Heather and Gary for, helping the group and sticking with them for, all the issues and changes and problems that we always encounter. It's actually part of our TRP process. So we actually, in a way, glad that that happened. We also have, so Heather Boone and Gary Levi are the two committee members that have been helping the group, or advisory committee members. Joseph, like Joseph mentioned, is a TRP advisor. We also have Avrum Gottlieb, who is our LNP representative, and Reza Mirza, who is our TRP mentor. So the way it's gonna go today, the group is gonna present. You have 20 minutes. So Angie, Atina, Fabricio, Sabrine, I hope you're all ready. We are excited to hear your presentation. And it's great that you managed to do it so early and for all of us to be here. So you're gonna have 20 minutes to present. After that, the committee members will ask questions. We can have several rounds of questions depending on how many questions the committee group has or the other members of the examining committee. And then we can open up for some questions from the group. So the question period is gonna take about an hour. And then we're gonna go into breakout room, for which the examining committee will basically ask us if you guys did enough to deserve the degree. Any questions?
Okay. Can people from the audience ask questions?
If we have time, yes. So we'll see how many questions the committee has, and if there is time, certainly people from the audience can ask questions. Okay, so guys, welcome, and please present.
All right, thank you so much for the introduction, Edita. So hello everyone, welcome to our defense, and thank you so much for being here. So my name's Atina, and I'm here with my colleagues Fabricio, Angie, and Sabrine, and we're here to present to you the effects of the COVID-19 pandemic on solid organ transplantation, an essential medical service. So today we're going to take you through the year-long journey that began near the beginning of the first wave of the pandemic, what steps we took along the way, and what we found, along with some brief takeaways. So first, I'd like to acknowledge our advisors who have guided us and supported us throughout this entire project, including our advisors from the University Health Network, Dr. Levy, Dr. Mucci, and Dr. Humar, as well as our U of T advisors, Dr. Boone, Dr. Fehrenbach, and Dr. Mirza. We'd also like to extend our thanks to Dr. Alex Haddad and the Trillium Gift of Life Network for their contributions and support. So with that, I'd first like to begin with where we started. Our team wanted to explore how the thoughts, feelings, and perceptions of those involved in healthcare affected decision-making. Second, we wanted to focus on an area that the pandemic has changed for the rest of time. And thirdly, we wanted to investigate this short project as a smaller scale example of how healthcare systems are affected by pandemics. And so we came to settle on organ transplantation during the COVID-19 pandemic. So, as many of you know, the beginning of the pandemic was filled with uncertainty and challenges. And unfortunately, our health system is already known to run at near maximum capacity. So, the pandemic just further delayed the care that patients would receive. Most crucially, as you'll see in the table here with the Canadian national numbers, transplant programs were also forced to slow down their activity. They had to take fewer donor organs and perform less transplants, meaning more patients on the waiting list died. So as a team, we wanted to know what factors contributed to these delays and how could we bring those transplants back up during pandemics. But perhaps it isn't that simple. So we mapped out our valley of death, which shows you on the left side what was currently happening that was problematic, and on the right side, the desired state, what we want to happen. So in the valley, these are the problems keeping the desired state from happening, which we derive from a combination of looking into the literature and through discussions with people we knew who were experiencing these things firsthand. At first, we were certain that there was a need to increase organ transplant activity, but after the course of this project, we've learned that it's not just a matter of numbers. So we modified our valley of death because we've realized that what's really happening is that people don't feel prepared to deal with a pandemic, and they'd like to be. In fact, there's a greater need to have informed guidance regarding decision-making to optimize organ transplantation. So it's not just a question of volume, it's more about preparedness. So we designed our study using the Toronto Translational Framework as a scaffold. This framework consists of a series of exploring and then narrowing down what we know. So this framework helped us to do three crucial things. First, understand the landscape of transplant. Second, see how the pandemic changed that landscape. And finally, figure out what we could do to help, given this is a one-year project and that everything needed to be done by us virtually. So to start, we decided on the scope of our project by focusing on the multi-organ transplant program at UHN, mainly because they're a well-known worldwide leader in transplant, known to set precedent in uncertain times. So we wanted to see what kind of challenges they faced, how they overcame them, and how they made their decisions. So our research question also reflected this. So to summarize our objectives, we wanted to define the impact of COVID on the MOTP, understand the experiences of the stakeholders involved, and develop considerations for managing resources to best deliver these essential services. And now I'll turn it over to Sabrine to talk about how we achieve this.
Great. So if we look specifically at the methods, one of the greatest things that we had to learn and had to recognize was that we had to ask ourselves a series of questions. And the first is, what was the information that we wanted to know? And the second, what are the ways that we can investigate it? So after exploring that, we settled on qualitative methods and developed a series of different methodologies, which we'll talk about, to answer our research question. So the first thing that we did was we created an organ map, which I'll talk about in a second, in terms of what that looks like. This helped us map out what organ transplantation looked like at Toronto General Hospital. The next thing that we did was we conducted semi-structured interviews. We then analyzed the data from those interviews as well as the organ map to finally answer our research question by proposing some considerations. So if we jump to the next slide, we can look at what that looks like within the Toronto translational framework. So the first thing is that we, as I mentioned, we had the organ mapping. So organ mapping is actually a tool that we created, and it is based off a service design tool called journey mapping. And essentially what we aim to do through this is that given that none of us were involved in organ transplantation at all, we had to understand the system that we were working with in order to potentially create change. So what we did was we spoke with key stakeholders at the multi-organ transplant program, as well as investigated some of the research documents and documentation that existed at UHN to map out the organ transplant system. And then later on, we wanted to see how the COVID-19 pandemic specifically impacted the MOTP. And so the semi-structured interviews provided us with that context firsthand. So if we jump to the next slide, we can see that it definitely is a lot of information overall, but I'm just going to give you a quick summary of the first part of our organ map. Essentially, what we had found was that there are three key steps within the organ transplant pathway. We found a pre-transplant jobs and things to do, the transplant component as well as the pre-transplant component. And we mapped it out across the living donor system as well as the deceased donor system. One of the things that we want to point out is initially we mapped out each process for every single organ at the multi-organ transplant program and found that there were a lot of commonalities. So this helped us reflect and consider the scope that we wanted to achieve. But this information was simply not enough. So if you jump over to the next slide, we also had to understand what had to happen for these processes to occur. And one of the greatest things that we learned and the greatest tool is communication. And so again, this is a lot of information, but just as an overview, we mapped again the pre-transplant, transplant, and post-transplant process and put the recipient, the organ recipient at the center of that process. And all of the communication networks that occur are mapped out here. But again, this is just a simple overview. And so we recognize in speaking with our stakeholders that it is actually much more complex. So if you jump over again to the next slide, you can see that we actually found out that for at least deceased donors, that there could be multiple organ recipients. And so this map just shows the complexity of the things that we were working with and the necessity for us to understand this system. And finally, the last big part of our process, if we jump to the next slide, were the semi-structured interviews. So now that we understood how organ transplant looks like pre-pandemic, now we could fill in the gaps and understand how the pandemic specifically impacted the system in order to propose considerations. So we talked to key stakeholders, including healthcare professionals, administrative staff, and patients and families. We then transcribed the interviews and analyzed them to develop themes, which Angie will talk about now.
Thank you, Sabrine. So as Sabrine mentioned, we developed 5 main themes after conducting our interviews. These themes are impact on clinical practice, virtual healthcare delivery, communication, mental health, research, education, and training. Overall, most participants reported satisfaction with the changes that happened at the MOTP during the pandemic. I will present a general overview of our results in our following slides, but I will be more than happy to expand on any of these topics during our discussion section. Also, we have added some participants' quotes at the end of our slides. So now if we jump to the next slide, we can see how the COVID-19 impacted clinical practice. Patients reported that the most pressing limiting factor for organ transplantation during the pandemic was resource availability. This was a result of, first, limited ICU capacity, restricted hospital space, and reduced procedural volumes. These procedural volumes were reduced due to operating room availability, a reduced number of trauma cases, and decreased national and international procurement. Now, if we move to the next slide, we can see how the MOTP implemented specific COVID-19 protocols to manage the pandemic. Firstly, a COVID-19 specific transplant impact. That was a team that advised the program on best practices according to the most recent literature and other programs processes. This is related to our second point in the slide, where the MOTP implemented specific protocols for donor and recipient screening and clinical management and COVID and non-COVID patients. Thirdly, they started to utilize more external resources such as laboratory and radiological tests. Now, if we go to the next slide, we found some administration challenges related to the provision of virtual care. There was a lack of virtual platform standardization. Independently of the platform use, most participants reported frustration related to technical difficulties. There is a subset of patients at the MOTP that don't know how to access virtual care and or not have the technology to access. Thirdly, there was a lack of training on how to deliver and coordinate this virtual care. Now, if we go to our next slide, we can see how patient impacts have been evident during the pandemic as well. The first one is related with the impact on clinical practice with the loss of the physical exam with virtual care. The second one is related to an increase for patients that live in remote areas. There was more accessibility for them for healthcare. It is important to clarify that patients prefer virtual care than in person during a pandemic for the reduction of risk of contracting COVID-19 at the hospital and time and money that they expend in in-person appointments. Lastly, virtual care have been more complicated for marginalized communities, and this is due to language barriers, access, and knowledge to technology. Now, if we go to our next slide, we can see how COVID changes all avenues of communications within the MOTP. These changes generating some challenges when communicating information, and our participants identified 2 main challenges. The first one, most healthcare workers and administrative staff reported that leadership did not effectively share information and the decisions and changes come down to the staff. And the second one is that MOTP standardized some aspects of communications, but other aspects of communications were not standardized, and this generates bottlenecks and delays in sending information out to patients or external stakeholders. In addition to this, as we see in the second bubble in our slide, healthcare workers felt that information for patients was not structured, and they were not as well informed as they could have been. Thirdly, patients believed that they were well informed and their healthcare team was accessible when needed. Going on to the next slide, we can see how was the communication with external stakeholders. Our participants recognized the excellent job of Trillium Gift of Life, that is the organ procurement institution for Ontario. And this was the centralized institution for provincial and national calls. And this was the preferred way for learn from each other, share experiences, and finally make policy decisions. So jumping on to the next slide. Thank you, Atina. So regarding the mental health of healthcare workers, staff reported increased burnout, fatigue, stress, and anxiety. Participants described two important negative aspects for mental health. The first one was a culture of resiliency, where staff are expected to be tough at the hospital. And the second one is the culture of avoiding discussion around mental health, citing that supervisors did not sufficiently check on the mental health of the staff. But paradoxically, hospital mental health resources were available at the hospital, but highly underused by the staff. On the other hand, as you see on the right of the slide, patients did not believe that mental health was substantially affected by the pandemic. Moving on to the next slide. From the start perspective, most regular research, education, and training activities had gone from in-person to virtual as well. With this change to virtual, many felt that they were inexperienced using virtual platforms and they were not given sufficient training on best practices for its use. On the other hand, staff increased the use of the MOTP website for patient education. Now moving on to our last slide for results. In terms of regular education activities, virtual trainee education were reported to be more accessible and wide-reaching, but less engaging, and social interactions were diminished during this time. Also, some participants expressed concerns surrounding the topics of education, which shifted more toward COVID-19 topics and away from other relevant topics for transplant. Now, if we move to the next slide, Fabricio will explain the last phase of our project.
Thank you, Angie. So at this point of our project, we reached the second part of the Toronto Translational Framework. We brainstormed to decide which ideas brought during the interviews could be helpful to guide the decision-making process in future pandemics. We needed to choose which ideas we would move forward as our final considerations. Our metrics was relevancy, impact, and comprehensiveness. So if we move to the next slide, here we're going to see the four main areas for consideration that we encountered: anticipation and preparation, maximizing existing resources and networks, standardization in the virtual environment, and caring for staff. We're going to discuss in detail. Next slide, please. Moving to the next slide. Yes, sorry. The first area was anticipation and preparation. Ramping down the initial phase of a pandemic is a policy that most likely needs to happen. That was what we heard consistently in the interviews. When there is no information about the disease causing the pandemic, it's needed to stop, understand the general picture, and then respond. That applies even to organ transplantations that needs to be seen as an essential service. We must have proactive planning of resource utilization. That means that policymakers, government, healthcare leaders should work in non-pandemic times to guarantee an adequate number of ICU beds, isolation beds, PPE when they are most needed. Our reserve in the healthcare system needs to be improved. As Angie already mentioned, provincial, national, and international collaboration among stakeholders is essential in a pandemic. Easy lines of communication should be established upfront in a way that can be rapidly utilized when other pandemics hits. Now moving to the next slide, we're going to talk about maximizing existing resources and networks. So the use of the local resource was something that the pandemic brought for us, and it has showed to be very useful. Patients can avoid traveling, commuting, parking, which ultimately saves their money and time. They can do tests and even procedures locally. As you might know, MOTP has a considerable number of patients from another province and even other countries such as USA. In parallel, this practice also limits in-hospital exposure, which is important when you have a virus circulating. On the next slide, we're going to talk about standardization and the virtual environment. It will be extremely important to have written protocols accessible through a centralized source. This would allow stakeholders to have increased clarity about where they can find health information and how to continue their work during the pandemic. During the COVID pandemic, several platforms were used. Overall, Microsoft Teams was preferred at MOTP. We encourage each transplant center to define which tools better suits their needs. However, the key point is to have standardization and training on the defined platform, which allows easy implementation when needed. Also, virtual environments should be better explored for education outside the pandemic, allowing expansion on its use in a future pandemic. Now moving to the next slide. We're going to talk about caring for staff. This is a crucial topic and is linked with mental health. The healthcare system should implement an open culture of discussion about the mental health of the staff. In general, people feel that this is on the underlines at this moment. The initiative needs to come from the leadership, which must come and check with all staff how they are doing and what are their needs. Also, strategies implemented to deal with mental health need to be checked in order to assess how effective they are. And in the next slide, we are going to see our future directions, which correlates with the last two parts of the TTF. Our next steps are mainly related to the knowledge dissemination of our findings. We aim to present our final report to the MOTP stakeholders and work in collaboration with the program to disseminate the findings for patients. We also aim to present our project at an international transplant conference and submit a manuscript for a peer-reviewed transplant journal. Next slide, please. We're going to see now our take-home message. We used a qualitative method to understand a healthcare crisis in transplantation. MOTP did an excellent job during the COVID-19 pandemic. This was shown by the patients' high levels of satisfaction. Nevertheless, there is space for improvement, and our considerations explore the topics that were consistently pointed out by participants. MOTP as a transplant center was our project space. However, the COVID-19 pandemic has affected all healthcare systems. Therefore, our considerations might be applicable not only to MOTP, but also to any other area in the system and might be important for future planning. Next slide, please. So thank you very much. This is the presentation of our journey, and we are open to questions.